Is it pressed? Yeah. So good afternoon, everyone. I know everyone is so excited, right? It feels like we're back in session, right? But we will be back in session in 4 weeks. So I want to thank my committee. Look at this. How many of you came, which is wonderful. It is great to see you. And those of you that are joining us today in the gallery, thank you for making time for us and for the hard work that you do for the state of Maryland. We really appreciate it. As you can see, we're excited for session and we're ready. HGO is always ready and appropriations, so we're partners. So we're going to get started. I want to first start by thanking staff for getting us ready. This couldn't happen without you, and it took a lot of work. Both Michelle and Andrea and Edith, I want to thank you so much for the hard work you do. To our 3 LAs that are the lawyers for the committee, Lindsay, Aaron, and Lisa, a lot of these policies and discussions do not take place without your hard work. So thank you so much for the work you do. And for OIS, you know, there's a lot of new equipment in the room and in the hallway. And they took care of that for us as well. This is a new era, right? Virtually. And those of you at home, they're making time to see us today. So good afternoon and welcome to this joint briefing for the House Appropriation, Health and Social Services Subcommittee and the House Health and Government Operations Committee. I'm Chair Jocelyn Pena-Melnick, and I have with me, go ahead and introduce yourself, please.
Good afternoon, everyone. I'm Delegate Emily Shetty, Subcommittee Chair on Health and Social Services on Appropriations. Thank you for having us.
Would you like to introduce your members, please?
Sure, I would love to. Thank you so much, Madam Chair. We are joined by our HSS members, Vice Chair Dana Jones. We have Delegate Alethea McCaskill. We have, who am I missing? That might be it.
You're supposed to have Acevero as well.
Right, Delegate Acevero may be joining us shortly. Thank you so much again for having our subcommittee.
Thank you for having us and working with us on these policies. This briefing is being streamed on the Maryland General Assembly YouTube channel. I kindly ask for your patience if we encounter any technical streaming issues, and they do happen. But we're human, so please be kind and patient. Panelists will control the transition of the slides. Before this briefing, all members will email a copy of each presentation. If you do not have these documents, please let committee staff know and we will send a copy. Please adhere to our usual committee rules of 1 question and 1 answer from the panel. If you saw the agenda, it is booked solid. Not 1 question and 1 answer from each panelist. Please keep your questions brief. Today, the House Appropriation, Health and Social Services Subcommittee and the House Health and Government Operations Committee will be brief on the Medicaid public health emergency unwinding and redeterminations, followed by a question and answer session. The Health and Government Operations Committee will then hear briefings on the report on coverage for individuals ineligible for Medicaid, Maryland Children's Health Program, or qualified health plans due to their immigration status, analysis of hospital and compensated care, related assessment, and healthcare expansion in Maryland, an update on the Commission on Behavioral Health Care Treatment and Access, and a report on operating rooms for dental procedures. We will begin today with Secretary Herrera Scott and Deputy Secretary Ryan Moran from the Department of Health. Secretary Scott, welcome to the Health and Government Operations Committee. Come up. And I know you have been busy and you can't seem to catch a break. So we are with you. How are you?
Very good, Madam Chair. Nice to see you again.
Nice to see you as well. Would you like to get started?
Yes. So good morning, Madam Chair and members of the committee. We are excited to be here today to talk about the Medicaid public health emergency unwinding. I would be remiss if I just didn't give some context to the magnitude of this endeavor that we're ongoing. It's certainly an unprecedented event to have 1.8 million Marylanders go through the system again. And under Dr. Ryan Moran's leadership, Maryland is really standing out as a state that's really doing well and ensuring that people in the state of Maryland maintain their coverage for Medicaid. I also want to thank all of you for your partnership and leadership, not only in helping to get the word out and how important this is, but certainly for all the support that you provided the Maryland Department of Health in doing this work and continuing to do this work through the end of fiscal year 2024, which is close to when the public health emergency unwinding happens. So thank you for that. And I'm going to turn it over to Dr. Ryan Moran. Some of you have met with him. Some of you may not, but he's the Deputy Secretary of the Healthcare Financing Division and the Medicaid Director. And he and his team have done a Herculean job in the Medicaid redeterminations. We also asked Michelle Everly, Executive Director of the Exchange, because we certainly couldn't have done this work without her. And though we know there will be a second session right after this, we thought it was important for her to have her have a seat at the table to help answer questions when they come up. And with that, I'm going to turn it over to Dr. Moran.
Great. Thank you, Secretary Scott, and thank you, Chair. Chair, I also want to thank you for holding court on my glasses in the fall that I left in your office. So I appreciate receiving those back today.
You are welcome. I almost kept them. Just kidding.
And thank you also to the rest of the members of the committee on what is, as the Secretary mentioned, a critical update on the current status of redeterminations. As mentioned, my name is Ryan Moran, and I am the Deputy Secretary of Healthcare Financing and the state's Medicaid Director for the Maryland Department of Health. Since joining the department in April of 2023, which simultaneously started the work of when the department officially began the unwinding process, we as a team have been laser focused on this historic work to ensure that we make the process for Medicaid participants as easy, accessible, and efficient as possible. It has been our guiding principle and the foundation of which we stand on as we navigate this work. During the PHE, if you go to the next slide, is an opportunity to discuss the magnitude of this issue from where we started to where we currently find ourselves. So individuals across the country during the pandemic, as you well know, maintain their eligibility for Medicaid enrollment. And Maryland's Medicaid enrollment at the start of the unwinding period was 1.8 million. And that was a growth from baseline prior to the pandemic starting of about 1.4 million individuals. And now with the end of the public health emergency that commenced in May of 2023, Maryland, along with all of our other colleagues and 92 million Medicaid participants across the country, are doing the unprecedented work of eligibility review for every single Marylander. I want to also talk about the timeline of this unwinding process, which states that states had the opportunity in their unwinding plans to CMS to select the period in which they would conduct this work. Maryland elected to go with the longest period of redeterminations process, which is a full year period. Some of other colleagues, such as those in Arkansas and other states, have gone for shorter durations in a 6-month time period. As Maryland has developed its approach in the next slide, we have partnered very closely, and I want to make recognition to some colleagues who are currently here, particularly those managed care organizations, and Joe Nguyen from the Managed Care Organization Association, to develop what has been the statewide Medicaid check-in campaign and has been jointly invested by the MCOs and the department. The purpose of the campaign is really twofold. The first is generating awareness related to the redetermination process for members across the state. And second, with our colleagues at the Maryland Health Benefit Exchange, really encouraging Medicaid participants to ensure that the state has their updated contact information in the systems in our enrollment and eligibility systems, so that when it's their time to send out notices over that 12-month period, that we have that information to be able to reach them. The campaign is produced in 2 primary languages, that is English and Spanish, although our communication toolkits and our work with providers have ensured that languages in terms of translation are accessible in 11 other languages and continue to add to that as we move forward. We will discuss in more detail, not just in terms of a multimedia campaign as it relates to the Medicaid check-in, but really our work as it relates to community and grassroots efforts with a multitude of other partners to help us spread the word. What you'll see here is that the media plan does include a comprehensive approach ranging from paid search, leveraging social media, digital media, television, radio. I often know our campaign is working when friends and colleagues are sending me snapshots of our pilot programs on applications like Nextdoor, digital streaming on Univision. I mean, every opportunity, every effort. And we've also been open to feedback in terms of partners. We've been open to you as members of the committee. Chair, you suggested that we blitz advertising in the Maryland Vehicles Administration, and we added that as part of our campaign as well. So in any crevice and corner that we can put this particular message has been our goal from the start. But outside of the campaign, perhaps the most important part of the process for the Secretary and I is using federal flexibilities, waiver authorities to help make the Medicaid process as easy and efficient for members. Maryland, particularly under this leadership, under this administration, we have been most aggressive in taking advantage of these waiver flexibilities. Right now, there's sort of a mixed bag of opportunities and flexibilities that you can pull, but we have a total of 15 plus. We are in the top 5 states of using these flexibilities. I want to bring concrete in terms of what that actually means. The first one, which actually coincides with legislation that was previously introduced in sessions, was linking SNAP and Medicaid eligibility. And for the enrollment process, we were able to turn on linking SNAP and Medicaid eligibility specifically for redeterminations ahead of the permanent fixes needed for our systems that express lane eligibility legislation required. To date, I'm happy to share that that process of doing so has led to more than 100,000 Marylanders automatically retaining their coverage because of that automatic link in this process. And we worked closely with the Maryland Health Benefit Exchange and our IT partners to ensure that we had that safety guard in place from the start. The other is in partnership with our MCOs, another flexibility that we've leveraged is training more than 400 managed care organization staff in partnership with the Benefit Health Exchange to allow them to help their members assist and enroll them in the process. And then the other one that I particularly would mention is a waiver flexibility authority that allows us to automatically renew participants who are at 100% of federal poverty level or below. And these individuals, right, if we don't have information within the system throughout the course of the pandemic, our hypothesis being because this flexibility is so important that these are the individuals who are most vulnerable or most susceptible to a procedural disenrollment. And I'll talk more about our impact there. I almost hate to show the next slide, if you will, related to stakeholder engagement, because we have been working with community-based organizations, community-based health workers in churches and church basements, to ensure that we partner with those individuals and those organizations to spread the message. But this particular slide just gives you a teaser of what outreach that the department has done in terms of finding and delivering through key messengers across the state, many of the lessons that all of us in the public health field learned during COVID. The campaign, in addition to all of that particular work, is the next slide shows that in partnership with our MCOs and their investment, we have 3 additional grassroots efforts that are specific. And specifically, these opportunities with these organizations, Coolin Associates, that's specifically supporting us in outreach to Hispanic and Latino communities, Live Chair Health, which you may know that name. It was essential in terms of the COVID vaccination work, in terms of their work in barbershops. And then finally, a partnership that will launch in January with Fabric Health, which is an innovator group out of, they started their work in the Pittsburgh area, but what they do is provide Wi-Fi services, and they provide on-site education and awareness of the Medicaid process. They will for us in laundromats. We've been using these terms of investments with these 3 organizations to augment our other work. And I will say that our MCOs and the department is continually looking at our zip code data analysis to figure out where we should target these resources across the state as well. It has also been a Herculean lift for us to engage providers on redeterminations, providers of all shapes and sizes, provider associations, every group that you can possibly think of. What's been most impactful in terms of this opportunity is we have a process that's leveraging our health information exchange system, CRISP, and we have 48 provider organizations across the state that have set up patient panels. Basically what it does, it provides providers with a file, a list of all patients who are on their list for the next upcoming 90 days so that they can call patients ahead of time, or when they're on site, they can navigate patients to resources to help them through the enrollment process. The data on this sometimes just is astounding in terms of when I look at it. Amongst those 48 provider organizations, since we launched this as part of redeterminations, in that 3-month, 90-day file that we have for these provider organizations, we have almost 200,000 participants that are on that list for providers to follow up on. The department strategically started to focus on federally qualified health centers, and the outreach to other providers has since expanded. Our hospital organizations are also part of this particular work, particularly in their outpatient clinic settings. Next slide. I also want to note that one of the opportunities in terms of direct outreach strategy in the process for individuals who may not make it through the enrollment process from a procedural termination, which that's a key term in terms of definition, which is when we send information to an individual and we don't hear back from them. That's what we note as a procedural termination within our particular data. The state has also elected with one of those federal waiver and authorities to extend our reconsideration period. I think I'm on the next slide, Michelle. Yeah. To extend our reconsideration period. So individuals, what that means is that individuals who may not have enrolled based on their redetermination assigned date, the state is allowing them a 120-day reconsideration period. That means at any time, individuals can come back into the system. If they are found to be eligible for coverage, then they can be re-enrolled automatically back into their MCO. It also means not just in terms of enrollment back into their MCO, but any services that they received over that 120-day period would also be covered as well. We're monitoring as a state very closely in terms of the impact of the 120-day reconsideration period. If you've been following along the national outlets, everybody has now learned the term of churn, which is essentially individuals who are up for a renewal date, do not apply, and then come back into the system that are deemed to be found eligible. Historically, in the state of Maryland, we find in a 90-day period, because that's what it was historically before COVID, about a 17-19% churn rate. But for our 120-day reconsideration period, for the 2 months of cohorts of renewals that we have so far, we're seeing about 25 to 30% of individuals who are coming back into the system leveraging that reconsideration period. Also be remiss, and I know that my colleague here would love to talk about it, but the Maryland Health Connection has implemented easy enrollment. So by which we know that through this process that not every single individual that goes through it will necessarily be eligible for Medicaid. So we've set systems in to support that they can be navigated through easy enrollment process to sign up with a qualified health plan through the exchange, which, as you know, provides them with low or no cost insurance options to ensure that they have some type of coverage as well. Next slide. Next slide. I also want to note that one of the key elements of the redetermination process is our access to our call center, which is done in partnership with the department and the Maryland Health Benefit Exchange. The call center is a way to obviously assist participants with the enrollment process, answer re-enrollment questions, guide them in terms of that process. I want to make a couple of notations in terms of language access related to the call center. The contractual relationship that MHB has requires that our customer service representatives have a minimum staffing to support Spanish-speaking representatives. And then for individuals that may speak other languages, we're using interpreter services from that perspective as well. And customer service representatives with MHB have access to that service. I want to make a key notation because this has been outlined in national press, if you will, but it's something that Michelle and I are monitoring very closely. And the secretary is call center monitoring based on the differences in the languages in terms of 2 key metrics that we report to CMS. Average speed of answer, abandonment rate. We're not finding any differences between languages at this time, and it's something that we take a look at. Next slide. One more point before we move to a quick section on data is that going through this process, Maryland has taken very seriously the mantle of responsibility to ensure that if there are corrections that are needed to be made to our systems, that we own them and that we make them. One of the ones that was identified over the summer is something that's known as ex parte, which is automatic enrollment into Medicaid. It's a process by where the state searches available data systems to automatically enroll Medicaid participants. The state has made numerous investments since the Affordable Care Act to ensure that those processes are strong. And prior to COVID was always a standard in terms of the percentage of automatic enrollment rates. This is particularly useful because it reduces administrative burden on the participants so that they never receive a paper renewal form in the first place. What we found in conversation with CMS, as well as 29 of our other state colleagues, is that we were conducting renewals at this way at the household level, which does not necessarily take into consideration the different eligibility requirements that exist between individuals, particularly children that have higher eligibility requirements. Secretary and I, upon identifying this issue, because our goal is to ensure that we make this easy, accessible as possible, we took immediate action. We were one of the first states to do so, recognized by CMS. We immediately paused procedural disenrollments for the month of August when we identified the issue in August. And then we worked with Michelle and the MHBE team to identify potential kids who are impacted in the first couple of months of the redetermination process to reinstate their coverage. That review process on the next slide was more than 5,000 kids were reinstated who were under the age of 19. And then Herculean efforts from our information technology teams, both in the DHS systems and in the Maryland Health Connection, to correct the systems so that we're conducting automatic enrollment rate at the individual level was completed in November. And we made a commitment as a leadership at the department that we would not resume procedural terminations until the system was appropriately conducting renewals to prevent any type of unnecessary disenrollments. What we found was once we made those system changes, about a 50% increase from July to the month of November in our automatic enrollment rate. So right now we boasted in November, obviously we had a number of cohorts who were in there, but a 60% automatic enrollment rate. We're also, this is data through November, and my only regret in terms of this data is we're not at a 1 million clips, right? We're at 923,000 individuals that we have renewed in terms of coverage. You'll see a 71% coverage extension rate. A number that we track very closely is the procedural terminations that I've spent some time talking about. That number is 11%. And then for anybody who's deemed ineligible, primarily related to income in this process, setting up those mechanisms for auto enrollment, easy enrollment for a qualified health plan through the exchange. Won't spend too much time on the next slide, although it looks like it's out of memory, is that we have been publishing our data on a monthly basis on our Medicaid check-in website. Everything that we submit to CMS, the public is seeing. We also provide a summary to distill the information from a number of complex measures so that public is more easily digestible. And then there's also data which we can review and provide to you related to our efforts in terms of easy enrollment. The last thing I will say before I make some closing remarks is we are using data, and we have data through September that looks at demographic and zip code trends to help us at the department pivot our strategy. And so in a recent review of that enrollment analysis, what we've done is we've been comparing demographic categories to our baseline enrollment numbers back to that 1.8 million members at the beginning of the pandemic period versus what we're seeing in terms of disenrollments now. We'll note, based on inferences of the data, and there's some limitations and caveats as there are when you try to aggregate it this size, but notably children, Black, African-American population, residents in Baltimore City, when you compare to our baseline enrollment, are maintaining coverage at a comparable rate in terms of what enrollment was. There are some demographic categories that you'll note when you see that adults between the ages of 21 and 44. There are also places in certain demographic areas in the Washington suburbs and in Western Maryland that we're noticing higher termination rates. So the department is looking at that and saying, well, what do we need to do about that? And the check-in campaign in partnership with our MCOs is ensuring that we're ramping up efforts to help those areas and to help those zip codes. Those are additional resources and advertising in Montgomery County, Hagerstown, Prince George's County. It includes expanded presence in buses, expanded digital presence and radio ads, along with extra billboards in the Western Maryland area. And that zip code data allowed us to forge a new partnership with Fabric Health that I talked about earlier, which will provide work in laundromats. In closing, I will say that the Secretary and I are asked all the time how Maryland stacks compared to rest of the country. And as much through the start of the unwinding process as I have tried to caveat a number of different stakeholders of reviewing data, that hasn't really stopped anybody from drawing particular conclusions about this process based on the differences that each state may approach the unwinding process. But perhaps the most trusted national source on this issue, which is the Kaiser Family Foundation, they have been analyzing data reported by states and reported to CMS. Some states aren't reporting publicly until it goes to CMS, which has a 90-day log. And what you will find in there is Maryland ranks in the top of the country in two key areas. The first is the metric in terms of percentage of coverage extension, and that was that 71% rate. And the second, which is in the top 10 of one of the states with the lowest procedural disenrollment rates. And the lower the number there, obviously the better. I will close, and then Chair, we're happy to answer any questions that you and members of the committee may have. And I just lastly want to provide an enormous amount of gratitude to the 700 Medicaid colleagues in the Medicaid administration who I'm proud to lead along their side, who I have found some of the most dedicated public servants who are fighting on the front lines of one of the most historic efforts of any of their career, certainly of mine, and I could not be more grateful and proud of them. I know that I speak for both of us when I say that.
Thank you, and thank you for your work and for all the hours that I know that we're not aware that you are putting into it to make sure that people do not lose coverage, right? Michelle, I want to just say thank you for helping with the slides. And I know you're on next on the next panel. So we're going to take one panel at a time for both committees. I'm going to actually now turn to Delegate Shetty to ask her committee if they have any questions, and then we'll come back to HGO with me, okay? Delegate Shetty.
Thank you, Madam Chair. Do any members of the Appropriations HSS Subcommittee have questions? I do, if I may. Thank you so much, Secretary Herrera-Scott and Dr. Moran, for the very informative presentation and for always being available to answer questions of members along the way. We appreciate that. My question relates to the work that you all have done. It's incredibly impressive on the sort of unwinding as it relates to children and their families. So it's really exciting that the redetermination rate remains essentially the same as in prior years. That shows that the work that you're doing is very effective. My question was, I know that there were several states that received a request by CMS simultaneously to separate out enrollment of family members as well as children who may be eligible. And I understand it's because the income eligibility threshold is higher for children than it is for maybe their parents. So have you all seen any data or can you share any data with us, please, on what's happening to families that may have been previously eligible for Medicaid, where the parents were eligible as well? The children are now re-enrolled. What has happened to the parents? I know that you all have provided a lot of communication to families about the exchange and other opportunities for them, but do they remain covered? Do we have data on those individuals?
Yeah, so what I will say is, so it's an excellent question. I want to mention another couple of points on kids too, that you mentioned, and then we'll have a comment and I'll answer your question related to our automatic enrollment rate. The first is children particularly have been an important part of our unwinding strategy. As part of this work, I failed to mention a key stakeholder group in that slide. I'm sure it was pictured, but was our partnership with schools and local education authorities to get the message out as well. Secondly, the Consolidated Appropriations Act, which started the unwinding process, ended with the end of the public health federal emergency, also required states to implement continuous eligibility for kids for a full 12-month period. And what that means is that regardless of any change in income throughout the period of year related to the household, right, to your question, if their kids would be required to be enrolled for a full 12-month period. Now, federal provisions, federal guidance actually required those updates to take place and to be required for those to take place in January of this year, January 2024. But Maryland, at the same time that we were dealing with the ex parte issue, we actually implemented continuous eligibility in September as another safeguard for individuals who are going through the redebt process, that they could rely on that continuous eligibility. The first portion of your question, which it gets to analyzing children versus household, is one that's the ex parte that we just fixed. And so I think Delegate Shetty, this is the first month of data that we have on the correct system. And I think it requires further analysis to dive in terms of who at the household level, right? Kids, we obviously can have data on and it can pull that, but who at the household level then was referred to QHP or another type of coverage access.
And can I just add, the one thing that is missing from the data that we can't capture is people that now have an employer-sponsored health plan. So that's the piece that's missing. So there may be people that we're not seeing in our data because now they have jobs that are providing them healthcare coverage. We don't have visibility on that. So the assumption can be that they don't have insurance, but it also can be that they have insurance through their employer now.
Thank you. Thank you, Delegate Shetty. Now I'm going to open it up for the Health and Government Operations Committee. Vice Chair.
Thank you, Madam Chair. And I want to add my thanks to the work that you've done. It's really Herculean is an absolute perfect description of it. So this is an in the weeds kind of question, but just so that I'm understanding the data on slide 16, when you refer to the 71%, so it's, 650,000 plus over 923,000. Is that 923,000 the number of individuals that would be the focus of this period of time? Because I heard 1.8 million, so this is half of that, and the other half is going to be focused on in the next 6 months.
Right. We are 7 months now, so that data is reflective of 7 months of cohorts that have gone through the process, which is the 900,000. The remaining individuals that are up for renewal will be in the remaining unwinding period that we have through May.
Thank you. And there's a cohort month, so it's not all at once, but every month we have another cohort, and that's the balance that's left.
Any other questions from our members? Anyone else? Seeing none, I do have more of a comment. I took a training, I think you did too, on it was I have done them all, Medicaid 101, 102. It's like a 3-day course. Those of you that have not done it, I recommend it highly. And they do them in the interim. And what is good about it is that you meet with different stakeholders and people from other states, so you can compare yourself to what they're doing. And we're doing great, by the way, I in a very humble way. Maryland leads. However, Oregon received a waiver from CMS to allow children to continue on Medicaid for like 5 or 6 years without doing a redetermination. Have we considered seeking such a waiver when this is done?
Yeah, so there are, in addition to Oregon, there are a few other states that have considered.
Mhm.
So the federal requirements require the full 12 months continuous eligibility.
Yeah,
And now other states are electing to go to that 6-year period of kids.
yeah,
We, I think in terms of our work and review chair, I would say certainly recognize the utility and the value of that as we think of terms of the values that we hold. We have not yet initiated a process to go through a waiver to receive that approval. Would require us to spend some time doing some fiscal analysis and what that would mean
Right.
for the particular state as next steps.
that would be great. Thank you. Any other questions? Thank you so much for being with us today. We know it's a hard job and we're glad you're doing it. And if there's anything that we can do, oh, wait, we do have a question. Delegate Shaleka.
Thank you. This isn't a question, it was a comment, hence
Go
why I
ahead.
held off. Ryan, I want to thank you so much for working with the folks that, who've been asking about the LTSS, which I had to look up, long-term support services and their billing questions. So, Secretary, I want you to know he's doing a wonderful job with them and has met with a nurse staffing agency in my area and has really helping work out some kinks in the system. So thank you for the indulgence. Thank you.
My pleasure. And I do want to say thank you for everything you're doing. Consider us a partner. If there's anything that we can do for you to make your life easier, let us know. As a new session begins, there are going to be a lot of policies that affect you. Let us know whether they're the right policies, what can make them better, whether they should go forward or not. We do have a partnership here, so I want to thank you in advance for that work. And I hope you have a wonderful day. I know that some of you are still on the next, in the next agenda. I know. But while I am still nice, I might as well say thank you. Thank you so much. So next we have number 2, which is the report on coverage for individuals ineligible for Medicaid, Maryland Children's Health Program, or qualified health plans due to their immigration status. And my colleagues, this was a bill, Senate Bill 806, that passed last session, and it's a report that they had to do and come back to us. Again, good afternoon.
Good afternoon, Chair Penny Melnick and members of the committee. It's good to be here continuously on another topic, again, with my colleague, Michelle Eberly. Today's presentation is to provide you and the committee and the General Assembly a report and an update, as you just mentioned, on required legislation last session that would compare the options of affordable healthcare coverage and dental coverage for individuals who are ineligible for Medicaid or qualified health plan coverage through the Maryland Health Benefit Exchange, but for an individual's immigration status. Today's presentation also fulfills requirements of the legislation that was to be done in partnership with MDH and MHBE. And we will offer options for offering coverage both through Medicaid as an avenue and QHPs to all individuals. Legislation spells out that the report should cover those under the age of 21 and also all ages and those 65 years and older, so that you can look at cuts of that. I also want to note that, Chair, at a recent request of yours, along the way as we were beginning to finalize this report, we also ran some rough estimates as it relates to coverage for children specifically under 18. So you'll see 2 cuts, under 18 and then individuals under 21 as well. To begin, I'll provide some background and then we'll go over the options that were laid out for both Medicaid and QHP. The U.S. Census, most recent estimates are there about 112,000 individuals in the state who are ineligible for Medicaid or QHP due to their immigration status. And that is roughly estimated about 30% of the state's uninsured rate. This includes, that number includes individuals who do not meet the 5-year bar, if you will, and that's defined as people who have not been lawfully present in the U.S. for 5 years or more, which is a Medicaid eligibility rule, if you will. As you know, federal rules do limit eligibility into Medicaid and QHPs. There are some exceptions Some of those particular exceptions are actually unique to the state of Maryland. Maryland Medicaid, as one example, covers emergency services for individuals who would otherwise be eligible, but for their immigration status, based on emergency medical care and emergency medical conditions. And the state, for those particular conditions, allowable by federal rules, can receive federal match for those emergency services. As you may know, there are very specific criteria that we must follow based on an individual's health that is deemed to be in immediate jeopardy based on those rules and their ability to revert, if you will, to a stable condition. Also, as this committee knows, another exception in the state of Maryland is the Healthy Babies Equity Act, passed in 2022, which allows for coverage for pregnant individuals, but for their immigration status up to 1 year for the child. Federal matching funds are available for this particular coverage through CHIP allotments, the Children's Health Insurance Health Services Initiative dollars that are a unique portion of CHIP through CMS. And as we've reported in other forums, enrollment for the Healthy Babies since our launch in July at the department, which went live July 2023, stands about 7,000 individuals enrolled so far. Further, I also want to note that, as Michelle will note, Marylanders who have undocumented status can purchase plans on the Maryland Health Benefit Exchange at full cost. And again, federal rules there limit the ability to use federal subsidies to decrease the cost of care directly to consumers who enroll in those programs. The last thing that I want to mention is that the department is monitoring CMS very closely on what we expect to be finalized rules from the federal government to allow DACA recipients to become Medicaid eligible. And so that proposed ruling was out spring. We expect it sometime in the spring of 2024. Before we get into the particular cost estimates that is outlined in the report, I wanted to provide some financial. I wanted to give you a little bit of the data in terms of methodology that we walk through, that the team walked through to come up with these estimates in terms of enrollment and cost expenditure. We use the American Community Survey through the U.S. Census Bureau, which is a known to be reliable and readily available public tool. It does provide demographic data or demography data, if you will, based on certain particular categories, and that those categories as it relates to the survey were scrubbed so that we could get to a list of the best list that we could from the state to do this report of people who are classified as ineligible due to immigration status that meet certain criteria to include as part of enrollment figures. So that is the foundation of which the report covers as it relates to where we are pulling for enrollment. We'll talk about per member per month costs at a later on later slides. Next slide. After estimating a population size of enrollment, this report lays out a number of different costs for 4 potential Medicaid benefit packages, and I just want to create a foundational orientation of the definitions of each of these as we follow along through the report, because we'll refer to them frequently. The first is cost estimates include Medicaid coverage for full Medicaid benefit package. So that includes everything that the state has to offer in terms of fee-for-service coverage, what our managed care organizations cover in long-term services and supports. And so you can think of that area, if you will, in terms of nursing facilities, medical daycare, those type of offerings. So it's the full Medicaid benefit coverage in number 1. Second includes full Medicaid benefits with the exception of dental coverage. So that was another cost estimate that was run. As you all know, based on legislation as well, dental is an expanded access that's available to every Medicaid participant now. So the second option includes all other benefits except dental. The third is services that are covered by the MCOs. And essentially what this means that you can think about as you review this report is somatic care, and it excludes, if you will, costs and services for dental and behavioral health, because behavioral health is a carve out from our managed care services. So that's another cut of the data. And then the fourth is solely just looking at prescription drug coverage and what would cost estimates be for prescription drug coverage. I will say some of the limitations outline the uncertainty as we move into the data related to some of the enrollment figures based on the population estimates that we have. The underlying enrollment assumptions, however, were developed in consultation with our team's actuaries that worked to develop this report. And we used sort of a barometer of current midpoint for the midpoint of these estimates. We used based on what we see in individuals, but for their immigration status in terms of their take-up of services that they're currently used for emergency services. So we try to use the best indicator that we have in terms of what's currently being used for services as a midpoint of that estimate. But we give you a range as the report lines up a low uptake rate and what that cost would be, and then a more aggressive high take-up percentage rate and what that cost rate would be. Next slide. So based on the review of this and the number of individuals estimated for the low, mid, and high take-up rates, this chart specifically gives dollars and cents. But I also want, as I walk through this chart with you, I want to pull out what the approximate coverage is for the midpoint range in each of these particular areas so that you can see as we whittle down, if you will, from full Medicaid benefits to more limited benefits, what that number does, and what it does by age range as well on the left side of this graph. So essentially to cover all Medicaid benefits for all individuals, the midpoint enrollment estimates at that midpoint would be about 20,000 individuals, 21,000 individuals. The cost over 5 years, as you can see at the midpoint for all ages, is roughly around $704 million for the full Medicaid benefit package. And annually, that's about $141 million per year. We run, so how we account for the changes in enrollment and the changes in costs, we do an aggregate run out of about 3% increase of an estimate year over the 25-year period to the 2029-year period. Moving down in terms of ages to cover those 21 and under with Medicaid benefits at the midpoint, you're looking at around 7,000 individuals at the midpoint, cost of over 5 years, $107 million or $27 million a year. And then to cover those 65 and older with full Medicaid benefits, the cost being $77 million and 15.4 per year. Later on in the presentation, as I mentioned earlier, in concert with our qualified health plan estimates, when I turn it over to my colleague, Madam Chair, we're going to provide estimates specifically for those who are under 18 in terms of those that we ran, as well as working with your office on understanding how applying premiums specifically to ages under 21 and what that would do with these corresponding considerations as it relates to the report. Before handing it to Michelle, I want to highlight some important implementation considerations as you review the report. The first is federal Medicaid matching dollars are, I'll say, generally unavailable for the estimates that you're reviewing. So you should think of these as state-only dollars. I will say there's some nuance and precedent that the state would need to look into, as well as petition CMS for the authority, where matching funds, if we went forward with these coverage options, you could get federal matching dollars continuously for the emergency services like we do right now. We would need to make overhauls within our MMIS system, our claims and information system, if you will, to track individuals going in and out of those particular coverage groups, individuals who maybe fall within this and then need emergency services, so that we can appropriately account and expenditure those to CMS appropriately to pull down federal match. There's only one state, I believe, who has precedent on doing that, and that has petitioned CMS successfully, and that's the state of California. So there is some precedent there. And then, like all of these benefit coverage and expansion, just noting the implementation costs beyond the estimates that you review today. And those would include things by additional capacity for eligibility worker staff, other system and IT changes. So with that, I'm happy to hand it to my colleague, Michelle, to walk through the QHP comparisons.
Thank you, Deputy Secretary Moran, and thank you, Madam Chair, for the opportunity to speak to the Maryland Health Benefit Exchange portion of looking at how we can get more people coverage through qualified health plans. You'll see that we use the exact same ACS data source. So we looked at that U.S. Census Bureau American Community Service community survey. And of that, when we looked at the percentage or the amount of undocumented individuals that are uninsured with income greater than what would make them eligible for Medicaid or M-CHIP thresholds, we found just over 69,000 individuals. And that was about 18.4% of the state total uninsured. When we looked at that and further broke it down, we saw 4% of that was less than age 21, 97% less than age 65. So that's really the population that we are looking towards. And again, those thresholds, as Ryan had spoken about, the up to 130% of federal poverty level for age 20 years and older, that's a Medicaid standard, as well as the up to 322% FPL. So we took that all into consideration. The other item we looked at, and this is something that is relatively recent as a result of ARPA, is the no upper limit on the eligibility for consumers to get tax credits. So used to be there was a cliff, we called it, at 400% of federal poverty level. Consumers were no longer able to get tax credits through the American Rescue Plan Act. That was extended or eliminated, and now everyone can get that eligibility. So when we looked at the above thresholds, again, those ARPA expanded subsidies are in place through calendar year 25. So we did include that. We know that that is an uncertainty because they are only committed through calendar year 25. Again, we looked at a low point, a midpoint, and a high rate that was based on Medicaid consumption rates. We looked at from what those rates were, we further reduced it in terms of what that take-up rate would be. And we reduced it because the cost of paying premiums and the cost of now having out-of-pocket fees that our folks will be responsible for, we realized that we wouldn't get the same take-up as someone who is getting free coverage. So we actually applied that in our methodology as well. Next slide, please. So this is the chart that actually shows the projected 5-year total costs for the QHB benefit package. And I'll describe a little bit again about what we're speaking to here. That low point, the midpoint, the high point. The top part of the graph is for anyone that would be Medicaid M-CHIP income eligible, but for their immigration status, if we were to provide them with a QHP. And then below that is not eligible for Medicaid or M-CHIP, and again, a low, medium uptake range. So when you look at this, we're looking at all ages, and we'll break it down a little bit further. You'll see, again, looking at the midpoint, if we were to do just folks that were eligible for Medicaid, we're looking at all ages of $610 million over that. You'll see if we look at just particularly under age 21 years old, it's 85 million plus, under 65, 598 plus. And then when you look over 65 million plus, it's 15 million. And although we found that the population for 65 is much lower, what drives that cost up is a cost for long-term support services. And then likewise, for those not eligible for Medicaid or M-CHIP, then their income threshold would make them QHP eligible, but for their immigration status, again, all ages, you can see the price tag on that, 501 million plus, under 21, the midpoint 3.5 million, and you look at the under 65, 475 million, and again 65 and over 34 million plus. So these are aggregated over the 5-year period. What the cost would be to pay for the premium tax credit, to pay for any cost sharing responsibility that the consumer would have, and then also taking into consideration the cost of reinsurance. Next slide, please. This slide shows a summary of the projected enrollment. So we talked about, again, using that ACS survey. We talked about reducing or putting in our modeling, lowering the uptake because of the costs associated. And again, when we look at a couple things that are very important to point out here. As a reminder, that full benefit, as Dr. Rand just said, includes the fee for service, the MCO, the long-term support services, dental and behavioral health. And when we look at that, we looked at the average annual enrollment of about 20,000, a little more than 20,000, with the PMPM costs at 582 and the total 5-year cost 704 million. So that's providing full medical benefits, which you've already looked at. The full medical Medicaid without adult dental, you can see that there. And again, I'll point out that midpoint, the PMPM cost, the MCO only, which Dr. Mayer went through, prescription drug coverage only. And then what's of interest to note here is that QHP benefit package. So we expect that we would see an uptick midpoint average enrollment, a little over 14,000. But the midpoint average PMPM costs would be 714,000. And why we estimate that that would be a higher percentage rate with providing QHP services is because folks that typically qualify for Medicaid are in lower income status. And so they would be getting a higher APTC. And again, we, the state would be paying that tax credit that would be applied to that consumer. So that's where you see that PMPM drive up. For those not eligible for Medicaid or MCHIP, regular QHP package, we estimated an average uptake of about 12,815. And again, that PMPM, $651, and assume that that would be a little lower because of a lower uptake of folks having to pay out of pocket. One other thing I wanted to point out is in the QHP benefit package for those eligible for Medicaid, we did include the cost of a dental plan in that because that's already included in Medicaid. So that does include that additional dental coverage. Next slide, please. So when we look at the coverage options, some of the implementation considerations, one, the federal subsidies unavailable. Obviously, the federal government will not pay those premium tax credits, so the state would have to cover those. It is, as Dr. Mann said, it is possible we could get a federal match for emergency services, but that's untested on the QHP side. We know California has been successful on the Medicaid side, but have not done anything if we were to do that through the QHP side. And then finally, miscellaneous IT costs. The estimated implementation costs on the QHP side are relatively minor because we already have folks that come through the system, but there would be some costs associated with that. And I'll hand it back over to Dr. Mann.
Thanks, Michelle. We're going to run through some conclusions and then happy to take questions from the committee. So want to provide a summary of the differences in sort of pulling this all together of comparing both Medicaid and QHP options for your consideration. We're going to also in this section review a summary of costs for ages of individuals who are under 18. And those are presented, I'll preface them as rough estimates without full actuarial analysis of which we can do at a future date, but giving ballpark figures for this number. Next slide. So for the full, as I mentioned earlier, the full Medicaid benefit offering, the richest of all benefits considering all ages, covering approximately 20,000 a year would benefit over the course of the 5-year period. That cost projection over any given period of time would increase over the fiscal year 25 to 29 annually on an annual basis from 128 million to 154 million. And again, we've used basically a 2.9% increase year over year. And the next slide shows that for the population, so that's all ages. So for the population that's under 21, again, the full Medicaid benefit offering, the richest of benefits approximately at the midpoint is 23.6 a year. And then here's where we find the rough estimate for kids under 18. You'll see the low portion of the range at 7.2 million up to 23.5 million at the highest, with the mid coming in at 15.3. The last portion of this is the report also takes into consideration for this committee to think about in terms of collection of premiums. We do that for the Maryland Children's Health Insurance Program as current practice. And so for the purposes of this report, to run estimates on if the state were to collect those for individuals under age of 19, which is we currently do, an average about $76. That rate's a little bit different depending on percentage of eligibility requirement, but that would yield about $800,000 in revenue at the to the state. We also note, and the report doesn't make any estimations on this, but as you might infer, premiums typically do dampen enrollment. So when individuals are required to pay some type of a premium, that does sometimes change the enrollment factors on the lower end of individuals needing to do that. And the analysis doesn't go into any details about what that dampening factor might be. I also want to point out, because it was from a previous conversation that we can pinpoint here, is that the federal continuous eligibility requirements for kids that I just referred to in terms of a full 12 months. The most recent guidance from CMS on that, as new as November the 1st, if you will, or the last week, October, states that actually states cannot disenroll individuals for the state not being able to collect premiums. So I want to note that only for, we are also at the department looking at how those continuous eligibility for the collection of premiums that was current practice under COVID for kids is impacted in terms of the resources that we have and are doing that analysis. And my assumption is, Chair and others, that you would want to mirror, right, to the best extent ability, whatever premium collection that we do on one side, we do for other side in consideration. So I just wanted to highlight that is an evolving portion of analysis for the department to take. Next slide.
Pick up from here on the QHP benefit package. We talked about a moment ago, the PMPM cost, again, being higher for those below the Medicaid income thresholds, and lower income, greater APTC. And for those above the Medicaid income threshold levels, again, $651. We do in the report assume in our modeling that the PMPM will increase, have an annual growth rate of 4.8% annually. So that has been built in. Our projected increase in enrollment for that period, again, below the threshold, we assume a small growth, and again, above similarly about a couple thousand people for each of those. Next slide. So the projected increase in costs, again, between 25 to 29, below the threshold, we're looking about 104 million on up to 140 million. We'll see that increasing annually. And you can see the numbers there again for below. This is taking into consideration all ages, all take-up rates, and the cost in calendar year 29, we're looking at ranges from, again, that 65.7 to 212 million, and above the threshold from 60 million to 185.9 million. What we need to really keep in mind is that all of this is untested. We're basing this on assumptions out of the American Community Survey, which we do know that they were not confident in how they record how many undocumented individuals there are. There may be some duplications in undocumented individuals already getting coverage through other programs, such as the Healthy Baby Equity Act. So we do know that all the numbers we're putting forward here are really estimates. We've tried to be conservative in our estimates, but again, they are estimates only. And then the next slide, please. Again, child-only population take-up rates, that is an area where we see the costs in 2029 ranging from 9.1 million and up to 29.5 in that cap midpoint, we estimate about 19.7 million. When we look at Medicaid versus QHP comparisons, assuming the midpoint take-up rate compared to QHP, the full Medicaid package would cost, what we have determined is 23% less PMPM for all the reasons stated above, and 15% more overall. The PMPM costs for age 65 are much higher under the Medicaid benefit, as we've talked about, due to the long-term support services. And I'll hand it back to you.
So to conclude, we'll say that combined expansion together, if you look at both Medicaid eligibility and QHP, you're looking at providing coverage at the midpoint around 30,000 individuals, essentially is what this slide is saying. The report lays out the impact of the number of uninsured in Maryland. If it were to continue to increase at the same annual rate for the general population, this particular expansion at this rate, using that midpoint of an uptake, would be about 0.5% reduction in calendar year 2025. Again, I think as the community continues to review these estimates, I think it's important to consider other impacts that may not be estimated or quantified as part of the report. There's a great deal of consideration thinking about the reductions in hospital and uncompensated care, and how that yields to total cost of care savings. The other thing that the department is recommending, and MHD and MHBE collectively, especially on the heels of Healthy Babies Equity, is incremental expansion. So that would allow the state with the ability to have more predictable enrollment and expenditure periods over time, and would allow us to really analyze take-up rates rather than the estimates, of course, that the survey that we are utilizing, which the next slide just sums up, does have limitations as Michelle discussed. There's a high degree of uncertainty in how we project those enrollment and take-up rates as sort of our best opportunity to do that. And then also the other thing I would mention is this analysis doesn't necessarily, like with any expanded benefit packages that may be presented related to Medicaid, necessarily take into consideration the uptake among individuals who are currently eligible, who may join the program as a result of the increased awareness, and that wonkily is defined as welcome mat effect, is what we call that in policy. So with that, I think that's the presentation that we provided. Happy, Madam Chair, to open it up for questions from you and the rest of the committee members.
You feel like you need a vacation after that presentation?
I've got one more left.
Delegate Shetty, why don't you ask your committee?
Thank you, Madam Chair. Any HSS subcommittee members have questions? Okay, thank you.
Okay, thank you. From HGO, we have Delegate Bandari, followed by Vice Chair Collison, followed by Delegate Hill.
Yeah, thank you, Madam Chair. Thank you, panel, for the presentation. Given the complexities identified in the report on the providing health coverage ineligible for Medicaid in our like qualified health plans due to their immigration status, how will the proposed incremental coverage expansion address the dual challenges that you identified, accurately predicting enrollment and take-off rates, and mitigating the potential increase in program costs due to welcome mat effect that you mentioned in your conclusion among currently eligible but unenrolled individuals?
Delegate, I think that incremental expansion, say taking population cuts of under 21 or under 18 or over 65, would allow MHBE and MDH more data than what we have right now in terms of what we're using, which is sort of experience of individuals taking advantage of or utilizing, if you will, emergency medical services. But the incremental expansion would allow us simply to take a look at the numbers and the figures over a course of period of time with a smaller population rather than generalized to all ages.
Yeah, I don't have anything to add to that. It would just give us a sense of what we will see. And of course, we don't know until people start to get coverage and as word expands. But if we could do it incrementally, that would give us some sense of some guardrails around it.
And maybe I'll add one more. I'll give you an example that's really top of mind and recent with Healthy Babies Equity. The departmental estimates related to that coverage was that any given time period, there would be about 6,000 individuals who would be enrolled in Healthy Babies. We launched that program in July. We're at 7,000. So we have increased the amount of projections in terms of that. Now, that then takes into consideration what the department needs to do from both an enrollment, resources that you have available, expenditure tracking in terms of following these particular funds as well from the budget perspective. So that's a good example of how incremental approaches may allow the department to guide future expansions.
And actually on the QHP side, Colorado just implemented a program. This is the second year where they have allowed coverage for undocumented individuals with a cap. This year during open enrollment, they met that cap within 2 days. So you can see what kind of demand there is.
Thank you. Delegate Collison, followed by Hill, followed by Lewis.
Thank you, Madam Chair, and thank you again for the intense work. And I do understand that these are estimates. And I'm sorry if I missed this, but Dr. Moran, you actually alluded to it in terms of how some of this might be balanced by, savings in uncompensated care and emergency care. Do you have a number on how much Maryland and the feds spend on emergency care for this population in a given year?
I know that we have it. I don't have it readily available, but certainly something that through the coverage group that we track, we would be able to get and ascertain, Vice Chair.
That would be helpful. I appreciate it. Thank you.
Delegate Hill.
Thank you, Madam Chair, and thank you for
pleasure.
the work and for the presentation. I want to just as a clarifying point and then follow up, I think, on what Vice Chair Cullison was just asking about. I want to be clear that when we're talking about under 21, under 65, that the under 65 is inclusive or not inclusive of the population captured in the under 21? Is it 21 to 65? Or is it all the people you called under 21?
Yes, it was everyone under 65. So it just gave 2 different segments.
Okay. And in terms of contextualizing for comparison, as you said, the estimates are difficult. Are there other programs that we can look at, including expansion to youth, under 21, 26, and so forth, where we can actually see whether the cost to the system of healthcare went up or down when we provided access to insurance? When we provided coverage, did it make a difference on our total cost to the state for uncompensated emergency care, delaying care, or any other things? Do we have any models that we can look at?
I think later on in the agendas gets to one of those agenda topics in terms of utilization of Medicaid expansion over time and what that implication has done to uncompensated care related to hospitals since that. And I think the presentation I think that Benny and Steve Ports are going to provide are going to review one of those estimates in terms, that's obviously much broader in terms of expansion, but gives a sense. We don't have that readily available or as part of the report.
So I guess what I'm asking is, in creating policy, we speculate, right? If we cover more people, our overall costs will go down. So it's not just the right thing to do, it's the cost savings things to do. And other people would argue we're just spending more money and it's not saving us. And you're saying in all the years that we've been expanding in different ways, there is no proof one way or the other about whether when we expand care, do we actually save overall cost?
There is proof, and I think you're going to hear about it after our presentation here. But when the Affordable Care Act came into being, we have been able, and there has been studies done on how much that took out of from the uncompensated care pool. So there is data on that. Looking at a specific age group, I don't know anything that we've done, and I don't know what's out there. But looking at the pool as a whole, there is data out there.
Delegate Lewis, followed by Delegate Shalega.
Thank you, Madam Chair. Thank you so much to our relentless and strong endurance team here from MDH. My question follows a little bit on Delegate Hill's. Had you answered her better, then I wouldn't be asking this. You mentioned that the cost to Medicaid that's estimated when expanding Medicaid coverage to the undocumented population in Maryland will cost the system, and it's just for the 0 to 20-year-olds, which is what I made a note of, would cost the system around $23 million or so, somewhere between 11 million and 36 million. I'm just wondering if we know what we would save if that population, just that one segment, were covered. What costs would be offset by that coverage?
So Delegate Lewis, we don't, that analysis was not included as part of the report. It would require additional study for us to do that. But it was not included as part of the original report, only cost estimates.
Delegate Shalega, followed by Delegate Chisholm.
Thank you, Madam
My
Chair.
pleasure.
If you could pull up page 28 of the report.
With the report?
It's called Table 1, Projected 5-Year Total Costs.
Of the report or the slide deck?
This slide deck, I'm sorry.
Yep.
Got
You,
it?
Delegate Schlega. Yep.
Okay, so I'm looking at the full Medicaid benefits, all ages high. Is this saying that taxpayers will need to spend over $1 billion? Am I reading that chart correctly?
I don't think I have the right chart.
Table 1, projected 5-year total cost. It has a 28 on the bottom left corner.
So for the table 1, 5-year cost for the Medicaid benefit, full
Yes,
Medicaid benefits.
All ages high.
Richest of all benefits includes adult behavioral health. That estimate for the high, in terms of the take up based on enrollment applied with a per member per month on that table says 1 billion. Yeah.
$1 billion.
That's right.
Okay, and who's paying for that?
Over the 5-year course of period.
Okay,
So that is, I'm doing quick math, annualized about 200 million per year.
and who's paying for that?
So as mentioned earlier, Delegate Schlega, generally they're not they're not federal matching dollars available for this work. There is federal matching dollars for emergency services that could be preserved. We don't go into the detail of what that number figure could be. We certainly could in additional study, but those would be state funds.
Maryland taxpayers are going to pay over 1 billion with these estimates. And I appreciate the caveat that it's difficult to estimate how many, because I noticed May of 2023 in Governing Magazine, Illinois took on a similar program to provide state funds and for health insurance to adults undocumented. They estimated the cost of that at 220 million. So clearly it wasn't the full, number we're looking at here. But within 3 months, that had grown to $1.1 billion. So have you looked at Illinois and what has happened with their estimates versus the actual numbers?
Delegate Schlega, I have not looked at the model of Illinois.
Instructive as to, that they have rolled out. I don't know how generous. Clearly at 220 million, they have more than 6.1 million people that the state of Maryland has. So it couldn't have been as generous as this, but that might be something. Also, I was just wondering, did you all having your charge to look at utilization by providing this benefit to undocumented immigrants? Were you able to project like how will that impact ER wait times that, you know, we're clearly dealing with today, as well as difficulty for people, you know, that are in the system to get into a family practice? Were you able to look at that? I know, you know, you didn't have a magic wand, so.
No, we did not look at utilization costs at all. So the charge of this study was just to look at what it would cost to provide a benefit package, not on the utilization or anything further than what's in this study.
My pleasure. Delegate Chisholm.
Thank you, Madam Chair.
My pleasure.
I understand it's going to be very difficult to project forward, given that we do know numbers estimate that we've had 9 million undocumented cross over the U.S. border in the South. Do we know, or are you in communication or contact with federal agencies to find out how many of those undocumented are coming to Maryland? Because if you're going to project forward, you're going to have a baseline of, all right, we suspect this is what it's going to cost per undocumented. How much is it going to cost 5 years from now if you don't really have that figure? And it's going to be tough to get that figure. So my question is, how much communication is there with the federal government on what Maryland should expect to be covering for undocumented this year, next year, the following year?
Delegate Chisholm, thanks for your question. The scope of this report considered U.S. available census data, and the current estimates in terms of policies that are happening related to dynamics that you're citing were not in the scope of the report for us to consider. We're using the 2021 baseline American Community Survey data, correct?
Yes, but I do believe there was, Johanna might know better than I, there was a, they looked at it on average, what Maryland has seen over several years for the average growth in undocumented, and I think was at 2.8%, 2.8%. So we did look at some assumptions of over past 5 years, what was that actual growth rate? I might be wrong on the 5 years, is it? 10 years, okay.
Thank you. I see no other questions. I have just a general question for you both. As the deputy director, right, for Medicaid, why do people have insurance? Why is it important for people in our state to have Medicaid?
Chair Milnick, I view it as the most important safeguard to allowing individuals, regardless of your life circumstances, to achieve your full optimal health status.
Does everyone that have Medicaid use Medicaid? Are there members that use it? Are there some that do not use it?
Utilization varies amongst an individual member.
And what is the utilization among young Medicaid recipients?
Individuals kids are some of our healthiest individuals that require preventative care. But, you know, you don't have a lot of instances, if you will, where you're getting into acute emergent, which is what plays out in terms of the data, in terms of cost estimates as well.
Okay, thank you. And again, your data was basically you're predicting with no certainty, correct?
Can you repeat the question, Chair?
Your data presented today is not 100% accurate, correct? There was a lot of disclaimer in your testimony, correct?
Correct.
All right, thank you. Seeing no other questions, thank you so much for your testimony today. Really appreciate it. Thank you for your work. Again, that was a report that had to be presented to us. We figure you hear it now, not during session, because during session we have 100 other reports that will be presented. So we're trying to save you time and have you ask the questions now on some of the most challenging issues, okay? Thank you for your indulgence and for being patient. I really appreciate it. Next, we have the third panel, which is an analysis of hospital uncompensated care, related assessment, and healthcare expansion in Maryland. And we have Vincent DeMarco, President of Maryland Healthcare for All Coalition, and Mr. Steve Ports Consulting presenting. Good afternoon.
Thank you, Madam Chairs, Madam Vice Chair, and members of both committees. Thank you for this opportunity. All of us know that in the early 2000s, the uninsured rate in Maryland was 13%, one of the higher ones in the state, in the country, with over 700,000 of our fellow Marylanders having no health coverage. In 2007, well before the Affordable Care Act, before we even knew the Affordable Care Act was coming, we worked with you all on this committee in the General Assembly to change that in Maryland, to expand healthcare in Maryland. And at the time, former House Speaker Mike Bush helped tremendously with this great observation that when people are uninsured and go to the hospital and generate uncompensated care, which goes into premiums, that's a hidden healthcare cost. We actually did a radio ad with that message. And thanks to Speaker Bush and all of you, the law passed expanding healthcare in Maryland in 2007 to 100,000 people before the Affordable Care Act. Then, of course, thanks to President Obama, President Biden, Vice President Harris, the Affordable Care Act and the Inflation Reduction Act allowed us to expand healthcare a lot more. Not every state did everything they should, but we did. And Madam Chair Peña-Melnick, you have a big responsibility for that, along with these committees and the legislature, for making Maryland one of the best states. We reduced the uninsured rate from 13% to 6%. Over 400,000 people have gotten health care. Today, we are presenting to you a report which shows that that has helped all of us. We have reduced the hidden healthcare tax that Speaker Bush talked about dramatically, over $460 million. Over $460 million of uncompensated care saved because of the healthcare expansions, money that would have gone into health insurance premiums. That chart over here behind us demonstrates it very accurately. So, we should not rest on our laurels. We did so much good for all of us, going from 13% to 6%. Let's go from 6% to 0%. We could help so many more people have better lives and reduce the hidden healthcare tax even more. So with that, I'm going to turn it over to my colleague and friend, Steve Ports, who will talk about this exciting report, which I believe is the first ever done in this state. And as Delegate Hill said, this has not been really identified before, but we have. I don't know if it's been done anywhere in the country in as detail as Steve has done. And Steve, as you know, was former Deputy Director of the Health Service Cost Review Commission, formerly a staffer here in the legislature. And since then, he's become one of Maryland's premier number crunchers, health policy analysts, and guitar players. And he is an absolutely wonderful human. And I'm going to turn it over to him to present his report.
Sorry, I didn't bring my guitar, Madam Chair, but we can do that
Wonderful.
some other time. I'll sing my presentation, but it's really a pleasure to be back in this room again. I haven't seen you for quite a while. I've been consulting for 7 years as an independent consultant. Prior to that, as Vinny said, I was with the HSCRC for 15 years. Prior to that, I was worked for you in the General Assembly for 16 years as staff to the Senate Finance Committee, staff to Ways and Means on the House side, and also for 4 years was Chief of Staff to the President of the Senate, Mike Miller, at the time.
I'm
So-
sorry, I'm laughing because that last presentation, how you brought your guitar and presented those numbers with the guitar. It would have made it a lot sweeter to listen to.
I've got- Sometimes that's the only way I can get people to listen to me. So it's great to be here. Today you've been kind of looking at what's happening today and some ideas for options for the future. I'm going to go back in time. I'm going to do a look back, and as Vinny said, this has really never been done before. Although I know Vinny's early on was following some of these uncompensated care trends. But the purpose of this study, and first I should thank, let's see. Yeah, got it.
I think
There
we're
we go.
gonna keep Michelle.
There we go. I want to first thank the HSCRC. There's a lot of great things about the total cost of care model in the state. One of the things that's fantastic is, like no other state in the country, you can get a tremendous amount of data. They have access publicly available data, and that's what we use today. So I thank the HSCRC for their guidance and also for their data. The purpose of this study was to look at the trends in hospital uncompensated care and to try to find out what the impact of two major healthcare expansions had on that uncompensated care, as Delegate Hill was asking before, and determine whether, one, their savings, and two, how those savings went on to the purchasers and payers of care through hospital rates. And then, to the extent practicable, or the extent that data are available, to try to determine, what's the who's left, what is left in the hospital uncompensated care, to the best we can. The data is very limited, but I'll give you the best that I could find through the HSCRC data. Just real quick, and I know you get presentations by the HSCRC all the time, and you're very familiar with them, but just very high level, the unique all-payer total cost of care model sets the rates for hospitals in the state of Maryland, and all payers, purchasers of care, pay those rates at the same amount. And in those rates, there's a provision included in there for the reasonable cost of uncompensated care. And then all those payers paid, their share of that. As a result, Maryland doesn't have public hospitals like other states do. And there's no incentive to, not treat patients who do not have insurance when they come to the hospital. So this is a great benefit of the hospital, of the all-payer system. So just big picture, I just want to give you an idea who those purchasers and payers are. You can see here the biggest payer is Medicare. 42% of all hospital charges, and as you probably know, the cost are derived from the federal tax base, and then Medicare also has some out-of-pocket costs. The second largest is commercial insurance. They derive their revenue from premiums on employers and individuals, and also through some out-of-pocket cost. And then Medicaid is 20% of the entire. So that's kind of the big picture of the payers or the purchasers of hospital care. What is hospital uncompensated care? It's care provided where the hospital did not receive compensation, and it's typically charity care and bad debt. And I'm not going to go in detail here. You've been dealing with the charity care issue for the past several years and are very familiar with it, but just on a broad brush, charity care is really free care. It's $200 for those under 200% of the federal poverty level, as in accordance with statute. Some hospitals, many hospitals actually have a benchmark that's higher than that. That's 250 or 300%. And then there's reduced cost care for individuals between 200 and 300% of the federal poverty level. And then you have put provisions in also for financial hardship for individuals under 500% of the poverty level. The second piece of uncompensated care is bad debt. And that occurs when a hospital is expecting to be paid and extends credit to the patient, but is not paid in the long run. Want to clarify that this does not, the data for this do not include denials. Payer denials is a separate bucket and not in this category. So, share of uncompensated care. Let's look at the slice of total hospital charges that represents uncompensated care. In fiscal 22, the amount in hospital rates for uncompensated care was 4.33% of all charges. And you can see here that half of it was through charity care, and the rest of it was from bad debt related to those three provide Medicare, Medicaid, and commercial. And as we mentioned, we want to see what the impact of a couple major healthcare expansions had on this uncompensated care. And the two that we're looking at today was in 2007 that Vinny talked about, this hidden healthcare tax. It began really in 2009 and it provided eligibility to parents and caretakers, relatives from 46% of the federal poverty level to 116%. And then expanded there was an existing primary adult care program, expanded that to 116% for childless adults. And then there was a small employer health insurance premium. And there was also this assessment that I'm going to demonstrate in just a minute to help pay the cost that Medicaid will incur as a result of the expansion. The second large healthcare expansion that occurred over the past 15, 20 years is the Affordable Care Act. And I don't have to tell you what that is because you're very familiar with it. It expanded Medicaid to 130% of the federal poverty level, created the insurance exchanges, which Michelle was here earlier, and provided some other provisions. But it was a very comprehensive, broad-based expansion. So Vinny was early on after the 2007 kept looking at these charts about what's happening to hospital uncompensated care since the 2007 expansion. And the blue bars here represent the dollar amounts of uncompensated care. And as you can see, it at times exceeds $1 billion, has exceeded $1 billion. But the way we really look at this is since hospital costs increase, change up and down, go up and down from year to year, we really look at the percent of total revenue that it represents. And you can see the green line here shows a marked decline beginning with the first Medicaid expansion in the percent of uncompensated care, a percent of hospital charges that uncompensated care represents. It was 8.29% in 2008, and then declined to 4.33%, as I mentioned before, in 22. It's a great story, but it's not the full picture. What we need to do is to add in, and this has never really been done before, look back, what were some of the assessments that were put in place in the past in the hospital assessments to help support the expansions. There are three that I've looked at and pulled data from. First was the MHIP assessments. That was prior to the exchange. This started in 2003, actually replaced something called a SAC program back then. And that expired with the exchange starting up, and it was about 0.8 to 1% of hospital revenue. The averted bad debt assessment I just mentioned was part of the 2007 expansion, and that was to assist Medicaid with the additional cost of enrollment. And that is established and still in rates at 1.25% of hospital revenue. This one's a little hard to really get your arms around, but the Medicaid deficit assessment, every time you see the BRFA during session, you hear the Medicaid deficit assessment from year to year. The first time this occurred was in 2009, and the purpose of this was during the Great Recession of 2009. We had employment losses, we had enrollment increases because people were losing their jobs or couldn't afford their health insurance. And there were also general revenue for the state was way down compared to expenses. So this Medicaid deficit assessment grew, and in 22, it was $294 million, but the HSCRC policy is that actually hospitals out of their margins will pay $56 million. So the amount in rates in 22 is $239 million. That's 1.22% of hospital revenue. So here's the chart that Vinny was showing back here. Let's see what the impact all in with these assessments. And you can see here that following the Medicaid expansion in 2008, it kind of leveled out and actually increased. And part of that was because of the Great Recession we talked about. And In 2014, however, following the Affordable Care Act, which was a much more comprehensive expansion, you saw a large decrease in the amount in rates, the combined amount in rates, hospital rates, for the assessments in uncompensated care. And then that sort of leveled out there toward the end, but there was a huge impact. So initially. So if you look at from 2008 to 2022, it moves from 8.96% combined to 6.6% combined, and that's 2.36%. And so that represents 460 million. And I say at least, this is a conservative estimate, and I'm going to explain that in just a minute. So Vinny asked the second question after we saw these numbers. Vinny asked, so what is the composition of the uncompensated care that's left, that 4.33%? HSCRC does have race and ethnicity data. It's still being worked on. And I was provided the data that are most comfortable, reliable at this phase. And the pieces of these data right here that they're very comfortable with are the numbers for Black and African American and white. And what you see here is in fiscal 22, the percentage of the individuals that represented uncompensated care by race category, 38% of them, of the charity care and bad debt, describe themselves as, in their reporting, as Black or African American. Now, 33% is a big gray area, and this is why we can't make a whole lot of make conclusions from this, because those individuals have identified as either other, unknown, 2 or more. So it's hard to tell what is in that bar there. But then we do know that those who have described themselves as white is 27% of that. So this is kind of a cursory look at that, and there's not a whole lot of story I can tell there, but at least it gives you a good indication at this point what that composition is. So findings. We all know that these healthcare expansions have provided greater access to comprehensive care because they have insurance, including things like primary care and preventive services. But we also learned today through this study that it's reduced hospital cost to the payers and purchasers of hospital care over that time. The savings in total that are up between 2008, before the first expansion, and 22 is at least 460 million when you account for hospital cost inflation over that period of time. And the reason why I say this is a conservative estimate, someone could easily argue that the Medicaid deficit assessment, even if we didn't have increased enrollment or expansion in Medicaid, that because of the impact on the state budget, that there still would have needed to be a Medicaid deficit assessment during the Great Recession, but perhaps it would have been smaller. I can't tell you what that amount would have been, so I just used the entire Medicaid deficit assessment. And I'll go back, see if I can go back here. So yeah, if you look at the blue piece of that bar, and I should probably go over this, the uncompensated care in the bottom of the gold is the gold at the bottom, and you saw that in the previous chart. The averted bad debt piece, that was part of the 2007 legislation, is the rust color. The MHIP, which was in place before the expansion and then expired, is the green piece of that bar. And the blue is the Medicaid deficit assessment. So if you look in 22, if that Medicaid deficit assessment, blue piece of that bar, was smaller, then the delta would have been larger and the savings would have been larger. So that's why I say this is, I'm saying that this is a conservative estimate. And so this has represented savings to purchasers of hospital care, including both public and private payers, consumers, businesses. There's not a pot of money out there. It's not like that those savings are sitting out there. Those savings have been, gone to reduce the growth in hospital cost. And it's, those savings then provide a potential to reduce growth in health insurance premiums and tax liability to public payers. And that concludes my presentation.
Thank you so much for your work and for making it really nice and clear. Are there any, why don't I let you go ahead?
Any questions from HSS subcommittee members?
You're welcome. Any questions from our committee? I see Delegate Chisholm.
Thank you, Madam Chair.
My pleasure.
Quick question. So you talked about all the savings to the hospital and then you mentioned commercial. What happened to commercial premiums due to the savings that you alluded to? And I'm curious because everybody I talked to is telling me commercial premiums actually have gone up. Deductibles have definitely gone up, and we're talking about 35% of a piece of that pie. So if you could answer that for me.
Yeah, so that would require a whole different data set. Looking at, this just looks at the provider side, the hospital piece of this. It doesn't look at the flow through on the backside. I do know that with hospital premiums, there are a lot of factors that play in there, and this would just be one a part of it. For example, you hear that prescription drug costs are going up, and things like that. So nothing, that's not part of this study, and you'd need an entirely different data set to assess that.
I think, Delegate, we can say that $460 million, had it not been saved by your actions, would have made premiums even higher. Would you agree, Steve? I mean,
Yeah, there's a potential for that.
yeah, that would have happened.
Thank you. Vice Chair Collison, followed by Delegate Rosenberg.
Thank you, Madam Chair. I'm sorry if I missed this, but tell me again, what was the period of time that 460 million was saved? Was it over that 15-year period, or, okay, so it was from 2008 to 2022?
That's correct.
Okay.
That's correct.
Okay, thank you.
And I want to emphasize that the first step, one of the main reasons it was able to be done is you all enacted a $1 increase in cigarette tax to help fund it, which dramatically reduced teen smoking and saved lives also.
Delegate Rosenberg.
Thank you, Madam Chair. Steve, how has enrollment in the Affordable Care Act benefited both the people who are insured or covered, as well as our overall system?
Yeah, so you're right. Because the Affordable Care Act was very comprehensive, it had impact both on that's why you saw that huge decline there, because not only was it Medicaid, but it was also private insurance, the QHPs. But you can see right out of the gate, there was a huge decline in the amount in rates, and then it flattened out over that time. So yes, there was an impact. The impact, so one of the things, it affected the U.S., how it was affected. The total cost of care, it helped the total cost of care model, certainly, because there are two tests for the total cost of care model. There's a cumulative rate of growth test, which this can help over that course of time. There are also some annual requirements, savings requirements. And it did help that early on. Those annual requirements, however, as things flattened out, it didn't really help to achieve some of those. And there are other incentives in place and other investments that the HSCRC has put in place to try to achieve those savings going forward.
Seeing no other question, thank you very much for your testimony today. Thank you for your work and thank you for being a partner to the legislature.
Thank you.
Thank
Madam
you.
Have a blessed day. Next, we have the update on the Commission on Behavioral Healthcare Treatment and Access. That is a report on House Bill 1148, which is one of the bills that this body and the Senate passed last session. After this, we have just one more panel. Thank you for your patience. Good afternoon again, Secretary Herrera Scott. And we have Ms. Erin McMillan, who's the Chief of Staff to Secretary Scott.
Good afternoon again. Sorry for the switch. We're trying to manage the
It's
slides.
okay, you do what works for you.
So I'm here today to give an update on the commission on the Behavioral Health Care Treatment and Access Commission. And, you know, we are certainly grateful to you all, Chairwoman Pena Melnick, for your leadership on this initiative. Behavioral health has certainly been a top priority for me since starting in January of this year. And we're glad to provide you with an update on not only the work that the department has been doing on behavioral health writ large, but then specifically the work of the commission. While I'm here, I also want to thank Alyssa Lord, who's the new Deputy Secretary of Behavioral Health. You could raise your hand. Many of you have not met with her, but she will be reaching out to all of you to get meet and greets. And certainly Ben Steffen for his leadership on the commission, helping to co-chair different committees. And last but not least, Delegate Cullison, who's not only been an active partner, but also participating in the geriatric work group. So thank you. Next slide. So this is the agenda, just to talk about some of the changes we've been making, an overview of the commission, and then the work done to date. Next slide. So when I first got into the office, I didn't really have an understanding of what we were doing in the behavioral health space. And so we really wanted to use the data to figure out where we were so we could figure out the path forward. And so what we did was pull claims from the ASO for calendar year 2021. We didn't have full claims run out for 2022, but we looked at it for 2021. And we mapped out all the services that were being provided in the state of Maryland, both for mental health and for substance use. So if we had any claim for any provider, that's what we mapped out across the state. We also then took our grants and the programs that we were supporting and mapped those out. And we did that by county. And what we started to see were where all the services were being provided, but then we mapped out what we referred to as the white space. And we mapped out where we were not providing any services in a particular jurisdiction for the total population. Because of the amount of white space and because of some of what we heard, we then did the same thing for children and children and adolescents. And as you can imagine, the services, there was even more white space. So as we thought about what services we needed to provide and where, we started to organize the behavioral health system of care into a continuum of care, very similar to what we see on the somatic side of the house, where you have primary and secondary prevention, primary care, urgent care, emergent care, post-acute care, and end-of-life care. Started to organize the services in behavioral health the same way. The buckets are a little bit different, but it gives you an idea of how we're organizing the current system that we have today. The pink denotes going upstream. The red denotes like a thermometer. That's more urgent care. So we have prevention and promotion, and the buckets that you see under there: primary behavioral health and early intervention, urgent acute care, and this is where our new crisis regulations that will be going January, and all the mobile crisis team and crisis centers will be going out, and then treatment and recovery. Under all of this, we're looking at data, the quality of the services we're providing, which is a work in progress, certainly health equity. How do we create an equitable system of care? Looking at our own data, we know people of color have less access to services, as well as our workforce initiatives. And this is not just happening within MDH. We're looking across all our partners, the Community Health Resource Commission, and then the work that they're doing at the Blueprint, certainly the Maryland Department of Education, as well as DJS and DHS, as well as all our partners that serve adults in the continuum of the behavioral health spectrum of care. Key updates from the last time or from when this commission, the law first passed, we now have a deputy secretary for behavioral health, which is Alyssa Lord, who I just introduced you to, and she joined us in August of this year. We have a new director of urgent and acute care. Tanya Schwartz was appointed in October. Again, we've reorganized the behavioral health administration to be the continuum of care. So not only have we thought about it in the work, but we've all functionally organized the administration to support those services. And then licensing and payment for mobile crisis team and crisis stabilization centers was resubmitted in AELR in December in anticipation of the go live in January. Next slide. So next, looking on the specifically on the commission, which is certainly informing what we've started. And the goal is to take the guidance of the commission as we continue to build out this continuum of care. So the purpose of the commission was to make recommendations to provide appropriate, accessible, and comprehensive behavioral health services. The duties were 14 specific charges of analysis across the continuum. There were 4 required work groups that made up the commission, as well as reporting an annual report due in January through 2027. Next slide. These are the work groups and their respective chairs. So we have a geriatric behavioral health group. We have youth behavioral health, individuals with developmental disabilities, and individuals with complex behavioral health needs. We have a criminal justice involved behavioral health group, and certainly a behavioral health workforce development, infrastructure coordination, and finance. And the chairs are in the right-hand side. We also have taken the commission members and assigned them to the work groups. And then we have many consumers that were not part of the commission that we opened up to participate in each of the work groups. With that, I want to turn it over to Erin McMullen, Chief of Staff of the Department of Health, who really has done an incredible job, not only in chunking out this work so that we could get you a comprehensive report this year, but it was a lot of work requiring a lot of people to get us to where we are so far. So with that, I'll turn it over to Erin.
Thanks, Madam Secretary, and thank you, Madam Chairs, for allowing me the opportunity to discuss this important work with you today. As the Secretary said, my name is Erin McMullen. I'm Chief of Staff at the department. And I want to kind of break down what the department has been up to support the commission. The commission's first meeting didn't kick off till November, but we started work, as the Secretary alluded to during session, to really inform kind of what we know about our public behavioral health system. And as the Secretary stated, there's 14 different things the legislation requires the commission to do, but we thought 2 were very foundational to inform that work. One being this needs assessment, and then the second being a literature review of prior reports and recommendations in the behavioral health space. So really that needs assessment, to build off what the Secretary shared earlier, using that claims data, we really did a hot spotting. So you can see where we have a wealth and where we have, frankly, fewer providers in our state. So we did that for both children and adults, for both mental health and substance use disorder services. We went a layer deeper on the children's services side. I think many of you know that there is really high behavioral health needs when it comes to children and youth right now coming out of the COVID-19 pandemic. So we also shared information and pulled together information for the commission that looks at other information like demographic identifiers for children and youth. We also mapped out, like the Secretary said, the white space at the jurisdictional level to see what we're funding and what is available. And then over the summer, we had a team of 8 staff do what I'm going to call it a really deep dive of all the work that has went to the General Assembly over the past 10 years in terms of reports and commissions. That team didn't just identify reports, they read all of them. They created an annotated bibliography to support the commission and really highlighted a top line recommendations or data that those different reports showed. Some of those staff were also tapped to help support the broader commission and its work groups. So we have 11 different staff across the department. That includes representation from the Office of the Secretary, the Behavioral Health Administration, the Developmental Disabilities Administration, and operations in our MDH healthcare system. This is really what I would call like an all hands on deck from the staffing perspective to really support this work. And those staff were selected not only for their subject matter expertise, but their policy analysis skills to really help craft recommendations for the full commission's consideration. And then just wanted also to share with you all, I really would like to emphasize that the materials that were put together for this were really reviewed at the highest level of the department. Myself, the Assistant Secretary for Health Policy, the Secretary, our Deputy Secretaries were all really involved in reviewing both the needs assessment and the literature review before they went to the full commission. So as I mentioned, the first full meeting was in November. And then the work groups, the secretary in her role as chair of the commission asked all of the work groups to take what was presented at the first commission meeting, the needs assessment and the literature review, and really go a layer deeper, take a deeper dive, identify areas that the commission wants to look into further. Perhaps there's additional data or other information that the work groups might want to consider. Right now, as we speak, our staff, I know, are working with the different work group chairs and committee members to make sure that their reports are submitted to the full commission. Our second full commission meeting is next week, where the respective work groups will frankly report out on their first work group meeting and talk about what their priorities are moving into the next calendar year. So I already mentioned that these were the two responsibilities for the initial work groups. I'm not going to dig into these more, but on the next several slides, I'm going to go through a little quickly, but you can see that there was a high level overview of what was discussed at each work group meetings. I just want to emphasize that this work group is staffed by both BHA and the Office of the Secretary for Geriatric Behavioral Health. We also have a work group that's chaired by Deputy Secretary Alyssa Lord that looks at youth, individuals with developmental disabilities, and those with complex behavioral health needs. We have staff from both DDA and BHA staffing this group as they have a bit of a broader mandate. We also have the criminal justice involved work group. This group is really responsible for looking at not just things that occur within the MDH healthcare system. So we operate several psychiatric hospitals, but it also looks at other court-involved issues. So our team from the Office of the Secretary and then the MDH healthcare system has been hard at work staffing this group. And then last but not least, we have the Behavioral Health Workforce Development, Infrastructure, Coordination, and Financing. Commissioner Bahrain has generously agreed to help staff this group and has been really instrumental in helping us think about what other data we can bring to the table to help complement our needs assessment using public behavioral health system claims. And this group is staffed by the folks at our Maryland Medicaid Administration as well as BHA. Just a shout out to the 11 staff members here who are busy helping support the work of this commission. I think you can tell a lot of work has went into this, but it really couldn't have been possible without them and their commitment to this work. And then in terms of next steps, as I mentioned, the commission is meeting next week, and we're hopeful to have a report to you prior to session so that you can see the first annual report of the commission, which will have a full detail of that needs assessment, literature review, and initial work group report out. We're also working to get commission meetings scheduled moving forward into 2024. So that concludes our presentation, and we're happy to take any questions you may have. Thank you.
Sorry,
Okay.
forgive me. Are there any HSS subcommittee members with questions?
Thank you. Any questions from the HGO members? Vice Chair Collison?
I don't have a question, but I wanted to make a comment that, you know, this is will be my 14th session in the legislature, and I've been serving on a number of work groups and commissions over those 14 years. And I have never seen an agency as well prepared and with the information that the work group actually needs in order to do its job when we had that first meeting on November 30th. So I just want to thank you, Madam Secretary, and Aaron, you as well, for the work that you and your team has done to be able to do this really important work. I mean, it's ambitious to say the very least, and you all have really set us up for success. So thank you for that.
Delegate Hill.
Thank you. Thank you very much. Just have a quick question. It's amazing how coordinated and organized you are. It says that you did a review of prior recommendations, the first work group meeting. The information about the list of relevant reports and what's going to happen and how we're going to hear about what you all decided is missing or not missing, or where those relevant reports have been applied or have not been, the recommendations have not been picked. How are we going to find out about that?
So I'll start and then I'll let Erin finish. All we did was sum up the information of the reports. We didn't do an assessment of the reports and whatever recommendations were in the reports, whether they were implemented or not. So for the purposes of the first commission, it was trying to bring all the information into one place. And then, as Erin said, annotated as a bibliography so people could see all the documents that were reviewed as part of the preparation for the Behavioral Health Commission. So people at least knew what had been put in statute or reports that were requested under other prior terms. So we just pulled it all together, but I don't know if you want to add anything.
Yeah, the only thing I would add is so that I would say we did like speed dating with these reports. Staff presented on all the different topics and tried to highlight some themes for the commission's consideration. And then the work group chairs were responsible for doing, frankly, what you just said, like really starting to dig into this more, starting to have the conversations around, are some of these still relevant? Are there things that are missing? So those reports are on their way to the secretary in her role as chair, and we're going to be hearing more about those next week.
Of what you want to do with that information. And then there'll be some interim reports back as opposed to another year before we hear what happens with that data.
Yeah, and just the commission's report to the General Assembly will include that full annotated bibliography. It's actually available on our website now. Happy to share that, but we can make sure you have that information too.
I would also say the slides from the first commission meeting are in that on the website. And to the themes that Erin was referring to, we did bucket all the like reports that talked about the same pieces of the behavioral health continuum of care into one group. So criminal, geriatric, et cetera. So you could at least, if you have a particular interest, you don't have to look at the whole bibliography. You can focus in on the areas of interest.
And just for clarification, once the report comes in, we will have a briefing to see if there are any recommendations. Delegate White.
Thank you, Madam Chair, and thank you both for your presentation. I wonder, as it relates to the recommendations and the type of recommendations you're starting to see to bubble up to the top, if maybe even as an unintended consequence of this review, that it will also expose and examine some of our own institutional and internal processes, and if there are things in which that may allow us as state agencies to work more efficient, to help provide better support and care for the delivery of behavioral and mental health. And so I wonder if that is something that you're also discovering through this process and can anticipate some other internal and maybe even institutional changes to occur as it relates to the provision of care.
That's happening with or without any recommendations of the commission. The commission, because of all the pre-work we did in anticipation, as Erin already said, has only had one big group meeting, and then the smaller group work groups that are opining now, and we're getting together for our second meeting. So I think it's too soon as far as the commission's work, but we've been doing that beforehand. So even before the finalization of the bill that put the Behavioral Health Commission, we had already started on the gap analysis. I can tell you with Deputy Secretary Lord in place, we are already looking at quality of care that's being provided in our facilities that we license, and are looking at our regulations. Are they good enough for expectations around quality of care? The way we have quality of care expectations on the physical health side it doesn't look the same on the behavioral health side. We are already looking at our own internal processes for grant making and how to streamline that. So we're not halfway through the year just giving out grants and people are not getting services. So we're doing that with or without the recommendations of the commission because it needs to be done. I will also say, as a credit to the governor and the governor's leadership, I am already working with DHS and DJS and now with acting superintendent Wright, reaching out in a way that I think state agencies are partnering where it makes sense to partner in a way that maybe we haven't seen in the near past.
Thank you. Thank you. Any other questions? Seeing none, I will say that one of the most important bills that we passed last session was this commission. And it's a 2-year commission. And I'm going to tell you why. Behavioral health is an issue that comes up in this committee every single day. When we look at the fiscal note and the impact, a lot of the times these policies don't pass because of the fiscal impact. We also carved it out, right? Which is a discussion that we need to have in the future. And I know it's not a topic that people want to touch, but we must look at the whole person as a whole, the physical health, the behavioral health. And we have done a lot on this committee, but we needed to look at the roadmap and to be able to do it in a cohesive way. And frankly, we didn't want to pass something to give them more responsibility when they already have a plan, but we want it to be a cohesive plan so that no matter who comes next, there's going to be something in place that is done across Maryland for all 24 jurisdictions. And this is an issue that is really important for this committee. It is important for me as a chair, and I know it's important for each and every one of you because you voted and supported it. Everyone, it was bipartisan. So we want to thank you for the work and all the efforts that you're putting because it shows. And thank you to those 11 people that were taken out of their job to be able to do it and do the work with existing resources. Because what you're doing, it's a lot of hours of work and reading and figuring out what works and doesn't work and where are the holes. So we want to thank you on behalf of the committee for the work you're doing and for the work you're about to do for the next 2 years as well. And again, consider us a partner. And we will have, for both committees, we will have a briefing on how it's going as well. And we thank you very much. And I want people to know behavioral health matters to us. It's important. It's important as physical health. Very important to be whole for this committee, for the General Assembly, for leadership. So thank you very much for your work. You have a great day. Okay. Next, we have our final panel. And we have a report on operating rooms for dental procedures, House Bill 1146 of 2023. And that was Delegate Kipke's bill. And we worked on it last session. As you know, I spent about the entire session every Friday afternoon at 5 o'clock. I spend it, and you guys are laughing, but I spend it with the hospitals, with the doctors, with the advocates every single Friday. That was my date. And it was this issue. So we decided to put in a bill and let the work continue. So good afternoon. And who would like to get started?
I think I'm going to open it up and then hand it to my colleagues.
Thank you.
Thank you, Chair Penny-Melick, and again, members of the committee. Last topic, I promise.
It's okay.
So
You have done well.
good to be here with my colleague, Ben Steffen from the Maryland Healthcare Commission and Devaney Hughes from the Maryland Department of Health's Office of Oral Health. Today's briefing is designed to give you a brief overview of a status update on a multi-agency, multi-partner effort that we are endeavoring to fill requirements of legislation, as you discussed from last session, on dental OR procedures conducted in hospitals and ambulatory surgery centers. Specifically, the report will be designed to review the landscape of operating rooms in these settings that are used by dentists for the treatment of patients. Noted, as you just mentioned, is the significant stakeholder awareness and work groups and meetings that happened last session that brought to light particular ways that dental providers may bring patients to an OR, including but are not limited to, and I actually think I'm on the next slide, if related to the severity of treatment and when the local anesthesia, if you will, is ineffective. This particular process last year of that stakeholder convening did yield and bring about barriers that some providers may have when providing dental care in these settings, particularly for pediatric patients. During the last session, Chair, as you mentioned, began addressing the needs of Maryland pediatric and special needs patients affected by these challenges through a multi-stakeholder work group effort. Those were yielded relationships on the next slide between multiple different partners, but the Maryland State Dental Association, Maryland Hospital Association, and other provider associations, just to name a few. Also, just noting that the previous 2 fiscal year budgets in terms of allocation for dental care access to address this in both the 2023 and in 2024, there were increased dental reimbursement rates. And then also the department is entrusted in working on an awareness campaign related to educational awareness of dental coverage and access and other coverage expansions. To provide you just a framework before I hand it over to my colleague Ben, just a recap of House Bill 1146. It did require 9 distinct elements. First, it required the Department of Health to examine the number of dentists credentialed at each hospital in the state. Also asked for the average time each hospital takes to credential a dentist, the number of operating room minutes made available to a dentist, things related to utilization rate of ORs, block scheduling, and then stipends paid, hospitals paid for anesthesiology services related to dental operating use. And secondly, it required the department to work with a few partners in partnership to conduct a survey with hospitals to identify the availability of hospital operating resources for dental use. And third, it then required the department to work with Maryland Healthcare Commission to conduct a regional needs analysis assessment for dental procedures that require anesthesia and moderate sedation. And secondly, to develop regional plans to ensure that the availability of certain operating space for the performance of certain dental procedures and generally relating to dental services. I also want to preface this presentation is that today is not to provide you the conclusions or to review the full set of data on each of these 9 requirements. It is to provide you an update that the department is actively at work and pulling together, particularly the analysis of that. And what we want to do today is talk about the partnership and the organizations that we've worked with, but also set timeframes on when the deliverables that's outlined in House Bill 1146 can be anticipated to be received by this committee in its full full work. So with that, I'll turn it over to Ben.
Thank you, Dr. Moran. And members of the committee, particularly Chair Penny Melnick, Chair of the Subcommittee of Appropriations, Delegate Setti. What I'm going to say today, I'm going to kind of piece together. We've learned a lot through the last 6 months about the delivery of dental health services in Maryland. I think that Deputy Secretary Moran is a little bit selling the department short. Early in that whole discussion, they, with a lot of, I think, initiative, raised reimbursement rates for ASCs that made it more attractive for ambulatory surgery centers to provide this service. I think it was an important first step in trying to provide a wider set of suppliers of this service. But I also want to report that based on the surveys that we have done of ambulatory surgery centers, we haven't seen too much uptake of that as of yet. We've seen more interest, but ambulatory surgery centers have reminded us that when you're delivering surgical care, it is an entire team of providers that has to be deployed. First off, of course, the facility itself, but the dentist, the pediatric anesthesiologist, and of course, let's not forget the nursing staff that if you've ever been to a ASC, you note is critical to the operation. So although the reimbursement rates went up, we haven't seen yet that what I would call multi-specialty surge centers really taking up the challenge to add this additional service. What we have seen, and it's noteworthy, is that one dental only provider in the state is moving relatively aggressively to expand the scope, the locations that they are offering services, expanding from the National Capital area to Baltimore, and then adding an additional facility adjacent or near the Shady Grove Adventist Hospital as well. The good news is these dental only facilities do offer a good solution. The bad news is it's one operator only. If I think most of you recognize that there should be a competition if you want to aim for high quality care. So we would like to see more operators move into this space, but they do point to a couple limitations. One is inability to contract with pediatric anesthesiologists, uncertainty about the level of demand. Last year, we did get significant information from pediatric dentists that there was a significant demand for this service, a need for this service, but what was the context for that demand? Was it pent-up demand because many families unable to access care during the pandemic had delayed routine dental care, and as a result, many kids had a whole mouthful of cavities necessitating a trip to an OR, or was this continuous? And I think one of the goals of our needs assessment will be to look at whether these are going to be continuing demands or we're really facing a surge that once that surge is resolved, the demand for the services may be diminished. As Dr. Moran said, we're in the midst of this study, but a couple key things have already been identified. We last year under Chair Pena Melnick's leadership guesstimated that about 300 pediatric dentists operated in the state. Based on the surveys conducted by the Maryland Hospital Association and MHCC, we can determine that about 220 pediatric dentists are credentialed somewhere. And I think that's one of the great objectives we ought to be thinking about is as many pediatric dentists as possible need to have access to an OR. They may not need multiple locations, but they need to have at least one. So I think that finding gave me some reassurance that we have the capability to find places for all pediatric dentists who need to deliver care in an OR. Secondly, we did also get some fairly hefty numbers of OR capacity that would be made available for dentists, something in the range of about almost 3 million minutes. Now that needs to be carefully qualified, but that's a lot of OR time, translates into about 25 ORs fully operational and dedicated to dental services across the state. I think it's a little high, and we're going to have to go back and look at that. But keep in mind that if we have places where these services can be delivered across the state, we will be well positioned to solve this problem. And lastly, we definitely identified significant gaps or access to care in Western and Eastern Maryland, both in terms of the pediatric dentists that are operating in those jurisdictions, as well as the ability of hospitals to provide OR's time to deliver those services. We have a lot yet to do, but I think we definitely are making a significant headway And I think as a group of organizations, we have a much better understanding of what the challenges are.
Thank you. Anyone else? Okay.
No, I'll just mention on this slide is the deliverables. Ben obviously shared some preliminary data in terms of what we're looking at, but in terms of what the committee can expect in terms of the finalization of our report. So within the next couple of months, you will see that we will continue to work in terms of the survey that we released in partnership with the Maryland Hospital Association, and review and analyze those survey results and its completion. We are reviewing and have pulled utilization numbers for Medicaid participants that will be part of the report, and then taking that utilization and then mapping it to Ben's point in terms of where OR and ASC sites currently exist and where utilization trends are, to determine whether we can see what the analysis are of access and enrollee drive times that require individuals to drive to receive those OR services, but mapped across the state, and then provide preliminary recommendations. We are also working with our dental administrative service organization, SkyGen, on new metrics that will support the overall needs analysis between when care is authorized and to when the delivery of service happens, and if there are any delays that we can see as part of that work. That's a new metric that we're beginning to capture with that work, which will inform the final report as well. And so you can see the timelines of deliverables of each of those, Madam Chair.
Thank you, and thank you for your work. I want to add that in the FY 2023 and FY 2024 governor budget allocation, and I want to thank appropriations for their work. There was $500,000 for dental education, as well as the 20 million increase that was referenced to, and the increase for the ASC, the rates. But there was also the Medicaid, and I want to thank you for doing this, decided to cover the silver diamine fluoride to be able to buy us some time as well. So thank you for all your efforts. The number seems a little high for me for the OR time. That seems to be a little bit, something's off. And can I just ask you respectfully, if you would be so kind and try to get to the bottom of it, because there seemed to be a disconnect, with what people really have available. So if you could do that, I really appreciate it. Does my colleague from appropriations have any question? Appreciations.
Well, we do appreciate having the opportunity to work on our state budget. But thank you, Madam Chair. Vice Chair, do you have any questions? No. Okay.
Yeah.
I have a brief question, if I may. We've been following a bit of the discussion around rates and reviewing of rates of different professions providing care to this specific population. Can you all provide any update either now or by writing to us about what the progress has been made specifically on pediatric anesthesiology? I know that that's been a subject of discussion and concern.
Delegate Shetty, I'd happy to follow up, and once we get the math and provide you an update on that.
Thank you, because they are key, right? They have to come on board. And we heard last year they made a request and it wasn't done. And we're going to find ourselves in the same place if we don't address it. So I'm asking the department to look and see what can be done, because it's a missing key and a very important factor here as well. Delegate Shalega.
Thank you, Madam Chair. And to piggyback on the chair from appropriations, 10 years ago, when I was on that subcommittee on appropriations, we were discussing this very issue. So I kind of feel like deja vu all over again, unfortunately. And former Delegate Ted Sophocles and I were able to get some budget language in that would benchmark the anesthesia care to I think it was a % of commercial rates. And I don't think that was ever implemented. So if you could look at that and see what happened with that. I tried to Google it, limited, I know there was a report in 2013, but I would just echo my colleagues' concerns about the anesthesia rates and what's being done to make sure that we're able to provide this important dental service to children. Thank you.
We've looked at anesthesia rates across Medicare, Medicaid, and the commercial market, that commercial rates are quite a bit higher than Medicare rates, and Medicaid tends to fall a little bit lower. But when the fee schedule for Medicare was put in place, the anesthesiologists were very reluctant to participate, probably to their disadvantage. Medicare rates, when you look at Medicare rates relative to commercial rates, there's a significant gap there. If I was an anesthesiologist and I wanted to benchmark a rate, I probably would pick the commercial rate because it is quite a bit higher, and it has not been resolved, even though the Medicare fee schedule has been in existence since 1990. We haven't reached a resolution yet, but those gaps really do garner provider attention. Why is it so much different? I won't say commercial rates are too high. They're just very different.
Follow up, I believe that was chosen again 10 years ago because we benchmarked the dental rates to commercial. So they weren't just picking it out of a hat, but I think there was a logical connection there.
I understand.
Thank you.
We have Delegate Martinez followed by Delegate Hill.
Thank you, Madam Chair.
My pleasure.
It is great to be back.
Oh, it's great, isn't it?
It is. My question goes to the 500,000 that was mentioned allocated to education. If you could just go into detail about who we're educating and what, just because I'm unsure.
So, Martinez, the department is currently working on a communication plan that would work on allocation of those funding dollars that was allocated and to provide the best sense in terms of how those funds are utilized to provide dental education. So we're in the midst of putting together a plan on that, which will also be part of the report that we'll provide in the next couple of months too.
And if I may elaborate on that, what we found out during the meetings is that a lot of these babies, their whole mouth was full of cavities because a lot of times they went to bed with the bottle in their mouth while they slept. It has sugar. There's a lot of sugar in whether it's the juice or whether it's the milk. So it's education for the mom or the caretaker, the grandmother, the community, that you do not put a baby to bed with a bottle in the mouth, right? Just simple things like that. And we thought, why not? Why take it for granted? Why not go out there, put some money into it and educate the community so that they know what should be done properly, right? So that's what it's for as well. Delegate Hill.
Thank you, Madam Chair, and thank you for the work and for the presentation. Mr. Steffen, as you all do this work, what I'm wondering, I know it's not explicit in the bill that this is based on, but I've recently been hearing more and more about the role of non-competes in making it harder for us to have sufficient providers in this area. And I'm wondering if in the scope of this work that you're doing, it would be something that either you could also take a look at, or whether you think it's too left field to be included.
Thank you for that question. I'm aware that this is a major issue for MedCai. It's accelerated by the acquisitions that are going on currently across the country and in Maryland, particularly as it relates to physician practices, but it's also commonplace in ambulatory surgery centers as we see major operators moving into not necessarily completely acquire, but take ownership interest, significant ownership interest in all of these types of operations. Right. So I think that it would be better if we followed that legislation. It's focused specifically on the limiting factors that lead physicians to actually leave the state.
I've been contacted by dentists, many of whom are having the same problems because they start out in someone's practice and the non-competes require that they go 50 or more miles away. And so they're not able to continue the care or practice at the same facilities and there are a few facilities with the OR available. So it was raised to me actually from the dental community.
Well,
So,
as part of that, a discussion with the dentist, we would include.
thank you.
That as a factor.
Yeah. Yeah. Thank you. Any other questions? Seeing none, I just want to thank you for all your efforts, and all of you have been there during those, were there during those meetings. Been, helping out, during session on Friday afternoon. So I want to thank you for all the work that you're putting. I know we come to you with so many issues. I know it's overwhelming. But these are issues that affect all our constituents, and we need to find solutions. So we don't just want to come with problems to you. Let us know how we can be of help as well. If it makes it easier for us to pop in the room, to encourage people to do what's right, we will do that. If it's legislation that is needed, if it's a phone call, let us know as well, okay? Consider us a partner. And I want to thank everyone that was here today to provide the testimony on all these issues that are so important. Thank you for your hard work. We really are very grateful and do not take it for granted. I hope you have an amazing Christmas, a great holiday as you celebrate with your families. And we look forward to working with you and seeing you in January for 90 days. For the committee, will you be so kind and stay seated just for a second after we go off, just to give you an update on the committee, all right? You have a blessed day, everyone. We have to go off for a second. It's a new system.